Yes, I'm ready.
Let's get started. It is top of the hour. It is my honor and privilege to introduce today's speaker, Dr. Juan Bustillo. So Juan joined UNM in 1996, coming from the Psychiatric Institute in Maryland, where he completed a 3-year fellowship in schizophrenia research. Before that, he completed his residency training program at the University of Texas at Galveston. Dr. Bustillo is a very distinguished researcher. We're very proud to have him as a faculty member. Some of his accomplishments include receiving a number of grants from NIMH R01s, and his area of interest has been studies on schizophrenia and first episode psychosis with neuroimaging. Dr. Bustillo was actually in the DSM-5 task force of schizophrenia, and of course that means only the top in the nation were part of that group. In addition, Dr. Bustillo has been a leader in the review committees at NIMH, specifically the Interventions Committee. He has over 150 publications. He is a member of ACNP, and he was the first faculty member who received a named professorship, and that is the Uhlenhuth Family Research Professor. He is a terrific, not only clinician, but also a teacher and mentor of many of our junior faculty and residents. Juan, Dr. Bustillo, my pleasure to introduce you.
Thank you very much for that very kind introduction, Dr. Toin, and it's my pleasure to be giving grand rounds today. I think I missed last week's presentation by Dr. Quinn, unfortunately, which was the opening presentation. I was on vacation. So I'm going to spend the next 45 or 50 minutes giving you an update on the treatment of schizophrenia. Now, I was looking at the people that are joining us today, and several of you have heard versions of this presentation over the last 25 years. I've probably given 4 or 5 versions of this presentation, so I hope you'll be tolerant and not bored by some of the things that are going to be very similar, and hopefully a few things are going to be somewhat different. I'm going to really work towards leaving at least 10 minutes at the end for questions. So these are my disclosures. And this is really an overview of the presentation. So I'm going to spend a few minutes talking about the problem of what we know as schizophrenia. And then I'm going to spend the bulk of the time talking about 4 phases of the illness. Maybe that's not the right term. It's 4 conditions that we as clinicians often encounter in taking care of patients with schizophrenia. So the first episode of psychosis, recurrence of psychosis, persistent psychosis, and functional impairment. And I'm already giving you the punchline for all those 4 there on the right in the orange text. So that if you have to leave early for any reason, maybe you'll remember that, at least that. And then I'll give you a little bit of a summary of what we discussed, and hopefully we'll have time for questions. Here you have something that is not going to be a surprise to most of you clinicians. The diagnosis of schizophrenia is based on the presence of psychotic symptoms. Psychotic symptoms represent a major disturbance in reality testing and usually characterized by delusions, hallucinations, disorganized thinking, and disorganized behavior. Psychotic symptoms are also called positive symptoms. Of course, they are not pathognomonic or exclusive of schizophrenia. And here you have in this a picture, you have other common diagnoses that can present with psychotic symptoms, mainly bipolar disorder. In about a fourth of patients will present with psychotic symptoms. Depression, severe depression, a way lower percentage. And then we have this sort of vaguely defined intermediary border diagnosis of schizoaffective disorder that we all struggle with often. However, so let me see something here. I need to. Okay, so however, schizophrenia doesn't only present with psychotic symptoms. Like I said, psychotic symptoms and positive symptoms are the same thing. And here you have them listed on the top left corner. Patients often have what are called negative symptoms. And negative symptoms are, as you're familiar with, reduction in normal psychological functions. They can be reduction in emotional expression, reduction in the amount of speech. Patients with schizophrenia also have full-blown mood symptoms, and that makes the differential diagnosis difficult. About 10% of patients with schizophrenia sadly end up committing suicide. And patients of schizophrenia, importantly, have cognitive deficits. And the cognitive deficits are across many cognitive domains. Let me see if I can get rid of this. I said many cognitive domains, memory, attention, concentration, and all of these symptoms affect to larger or greater extent functioning in the community. And we'll talk about that more in a minute. Let's see what's happening. All right, the other element of the diagnosis of schizophrenia to keep in mind is that it is a chronic, serious illness, and there is an element of deterioration of function for many patients, and that's what's portrayed here. Now, we, of course, do not know what's the cause of schizophrenia. We don't know what's the pathophysiology, what is the intrinsic mechanism that leads to schizophrenia. However, we know a few things. We know that there is too much release of dopamine in the striatum. And I'm having trouble with this. So what this a plot on the left shows is a series of studies that use PET with radioligand to measure release of striatal dopamine. And the studies that are to the right of zero, and each of these black squares represents one study, found that there was greater release of dopamine in the striatum in patients with schizophrenia compared to healthy control. So most of the studies reliably identify increased release of dopamine in the striatum in patients with schizophrenia. This is not exclusive to schizophrenia. It has also been seen in patients with bipolar disorder type 1. But importantly, it's seen in patients with psychosis regardless of whether they're treated with antipsychotics or not. So this seems to be something that is intrinsic to the illness. So that's something important to keep in mind when the family members or the patients ask you, well, what's the cause of this? What's happening to me? Now, the other thing that is really useful, and it fits nicely with the previous slide, is that we know that the mechanism of actions of all the drugs that work for psychotic symptoms, the antipsychotic drugs, involves blockade of dopamine D2 receptors in the striatum. So there's, on the one hand, increased release of dopamine in the striatum. That's part of the illness. And the best treatment that we have works by blocking the effect of that dopamine in D2 receptors in the striatum. And this graph on the right, let me take a minute to show what it means, because I think it illustrates an important point. So on the y-axis, you have improvement in psychotic symptoms. Higher is more improvement. On the x-axis, you have proportion of dopamine D2 blockade by a drug, any antipsychotic drug. And each of these diamonds represents an individual subject. So the green diamonds are subjects that had a D2 blockade, and it also illustrates the amount of clinical improvement after the exposure to the D2 blocker. So here you have two subjects in green where they had 70% of D2 blockade during the PET, and they were very much improved. And you see that there's a relationship between the amount of D2 blockade and improvement. And it's not a very strong linear relationship, but there is a relationship. So the other important point from this graph is that there are patients that have much more D2 blockade for whatever reason, higher dose or whatever reason. So if they have more than 80% D2 blockade, those are the subjects in red. Those patients start to experience extrapyramidal side effects or akathisia with the same drug. So this is really, to my knowledge, the first time that mechanistically it was illustrated how the antipsychotic effect of drugs can be separated from the so-called neuroleptic effect of drugs. The neuroleptic effect of drugs is the EPS causing a mechanism of the drugs. And not surprisingly, 50 years ago, we stopped calling these drugs neuroleptics and we started to call them antipsychotics. The other important thing in terms of the pathophysiology of schizophrenia that we know is that this is indeed a brain disorder. So this is a study from our group. This was a multi-site study, a large number of patients with schizophrenia and healthy controls. And this is an MRI study. So we're basically looking at structure of the brain, in the cortex in this case. And so all these bright colors that are illustrated here in these images show areas of the cortex where patients with schizophrenia have reduction in gray matter density compared to healthy controls. And 2 points are important. First of all, it's all over the cortex. So you see it in the cerebellar cortex, you see it in the visual cortex, you see it in the sensory cortex, and you see it also in some regions that seems to be more pronounced, and those are the temporal cortex and the prefrontal cortex. Now, this is mostly with chronic patients with schizophrenia who have been ill for years, treated with medications, but these similar findings have been reported in patients who have never been treated with schizophrenia. Even in people who are at risk of developing schizophrenia and have not been fully diagnosed, they already have some degree of cortical thinning. So this is a brain disease. Now, what accounts for this? So this cartoon illustrates some of the few things that we know about the postmortem literature in schizophrenia. So what seems to account for the cortical thinning is that there is a reduction in the number and the density of what's so-called the neuropil. So this is the neuropil. This is a pyramidal neuron. Yeah, and you have all these synapses in red and green, and this neuropil is very rich. Yeah, in schizophrenia, what has been repeatedly found is that the neuropil, density of the neuropil is decreased, the richness of the neuropil. Just as important in schizophrenia, there is no widespread loss of neurons. Yeah, so the number of the pyramidal neurons on the right is the same in this illustration and on the left. And the number of interneurons, again, is the same on the right as in the left. the size of the neurons seems to be decreased and the packing of the neurons is increased. And it is this collapse of the neuropil what seems to account for the reduction in cortical volume in schizophrenia. But it's really important to keep in mind there's no neuronal loss like we see in degenerative diseases or dementing illnesses. And that's also important for you to remember to tell family members and patients. Now, now we're going into the first episode. So the important things to consider in terms of treating patients with first episode are the following. As I mentioned before, making the differential diagnosis is critical. And this involves considering whether this indeed is going to be schizophrenia, bipolar disorder, or major depression, or substance-induced psychosis. The diagnosis, like in all of psychiatry, is clinical, based on gathering the most valid information. There's no test to make a diagnosis of schizophrenia. And detailed history from family, I think, is very, very important. Early identification is crucial, and that's because of the well-documented relationship between duration of untreated psychosis and outcome. So the earlier we make the diagnosis, the earlier we can start treatment and we can improve outcome. And that is illustrated here. So this graph illustrates a meta-analysis that was recently published.
Dr. Bustillo, I'm sorry to interrupt, but I think your slides are not advancing. We're still looking at pathophysiology on the screen.
Why is that?
I'm not sure. You might need to reshare your screen.
Okay. You're still on pathophysiology, okay? I'll resume share. Now?
Yes, you got it.
Okay, thank you very much. So what did you miss? What did I miss? So well, let's go back to duration of untreated psychosis. Are you seeing this slide?
Yes.
All right, thank you. Do you see the bar at the top that says you're sharing and stop share and all of that? Do you see that?
We see you are viewing Juan Bustillo's screen. So
okay.
We can see the slides. This looks appropriate. Yeah.
This looks appropriate. Okay, yep. Great. Okay, so I was saying that early diagnosis is critical because duration of untreated psychosis correlates with poor outcome. And this is from a meta-analysis. And let me explain this graph. So on the y-axis, you have the correlation, the strength and direction of the correlation between duration of untreated psychosis and a particular outcome. Numbers to the left of 0 are negative correlations. Numbers to the right of 0 are positive correlations. And on the y-axis, you have the different outcomes. So for example, for negative symptoms here, you see that for several studies in this meta-analysis, the relationship between negative symptoms and duration of untreated psychosis had an effect of -0.1, a correlation of -0.1 that was significant. All right, so the longer the person has been untreated, the more likely the negative symptoms are going to be severe down the road. The same for positive symptoms, for general psychopathology, for overall functional health. So this relation has been established many, many times. Now, we don't know what accounts for this relationship. At one end, there are researchers who say, well, this is perhaps evidence that psychosis is toxic to the brain. And the longer you've been psychotic, the worse your brain is going to be. There's not a lot of evidence for that in my view. On the other extreme, there's people who say, well, this is more like a confound. This is a cohort effect. And these are just patients there are patients who are quietly psychotic. And because of that, they do not come to the attention of the treatment team early on. Regardless of that, the association is there, and it makes good clinical sense to start treatment as quickly as possible. The basis of treatment in the first episode psychosis and later on is antipsychotic treatment. And antipsychotic selection is a very important big step. So antipsychotic medications that are available in the United States have had established efficacy for psychotic symptoms. And this is an effect that is seen in days or weeks. Now, most of these drugs also have established efficacy for relapse prevention. So that's seen months or years later. So when we come to what antipsychotic to use for the first line in the first psychotic episode, I think it's fair to say that any antipsychotic, it can be used except for clozapine. We'll talk a lot about that. Most likely olanzapine because it has a lot of metabolic problems. And I would submit that some of the old phenothiazines should not be used as first-line treatment like chlorpromazine and thioridazine, because these drugs have higher risk of weird systemic complications in the liver, in the eyes, in the heart. And it's critical to think that treatment is going to be in terms of many months or years. So thinking about long-term tolerability is critical. One of the worst things that can happen, and it has happened to me or to my patients, is that you start a drug and a patient, for example, has a dystonic reaction. I mean, that patient is going to be very hard to persuade to continue to take antipsychotic medication, even if especially when they're doing well. Almost as bad if you have a young patient, let's say a female, and she gains 20 pounds in the first month of treatment, like can happen with many antipsychotics. So you need to be very thoughtful about your choice. Yeah. And for inpatient docs, the idea is not just to get the patient well quickly in the hospital. I would submit to you that you want to choose a medication that can get the patient well and that the patient is likely going to continue to take. So selecting the antipsychotic is based on side effect profile. Before we continue on the side effect profile of the available antipsychotics, let me spend just one slide talking about the critical concept of atypicality. And this is a term that is becoming less popular. Now we talk less about atypical antipsychotics and more about second generation antipsychotics, which I think that change is appropriate. But what is the concept of atypicality? So very broadly, it's an antipsychotic that doesn't have neuroleptic properties. How is that operationalized? Well, I'm going to show you this study, and this is a very important study with the drug Certandol that is not available in the United States, but it is available in Europe. So I've chosen it because it illustrates very well the concept of atypicality. And there's no bias here because it's not being sold here. So atypicality involves equivalence to a standard drug, for example, haloperidol in terms of efficacy, and at the same time, equivalence to placebo in terms of extrapyramidal side effects. But, and this is the catch, both of these conditions should be present across the whole recommended dose range. I would submit to you that this is the most stringent and appropriate definition of atypicality. And let's spend a minute on the results from this interesting study. So this was a remarkable study because it involved 7 arms. Most studies of antipsychotics just involve 2 arms, the placebo and the drug. Here, they were really trying to stringently test the concept of atypicality for Certandol. So on the left panel, you have antipsychotic efficacy on the y-axis. Lower means better. And the first arm is placebo. And you see, very nice, there's no effect. But then there's 7 more arms, 7 more groups of patients. Three groups where patients were assigned to low, middle, and high doses of the experimental agent, Certandol. And also 3 groups where patients were assigned to low, middle, and high dose of the control active comparator, haloperidol. And what you see is that Certandol has similar efficacy to haloperidol across the dose range. And it's a very nice semblance of a normal distribution. So good for this so far. Now, on the right panel, you have percentage of patients that develop extrapyramidal side effects. And here, what you want to see in a true atypical is that across the 3 dose ranges for Certandol, the patients look like placebo. And as expected, across the 3 dose ranges of haloperidol, the patients on haloperidol look much worse than placebo and that the experimental. This is the pattern of a true atypical agent. And you will see in the next slide that many of the so-called atypical antipsychotics do not have this pattern or have never been tested thoroughly enough to be able to establish this pattern. So let's keep talking about what drug to choose. We've talked about side effects, about atypicality. What about effectiveness of the different drugs? Effectiveness is efficacy in a community setting, in a generalizable community setting. So on the left side, this is from the famous Katie study, another important study that I would recommend the residents to read carefully. And this was a study which is the largest outpatient study treatment, a randomized controlled treatment for schizophrenia ever done, 1,600 patients randomized to 5 arms. And this was done over 15 years ago. And the study tested the 4 atypical, considered atypical antipsychotics at the time, olanzapine, quetiapine, risperidone, and ziprasidone, and compared them with one lonely typical antipsychotic, an all-phenothiazine perfenazine. And of course, the expectation was that the atypical antipsychotics were going to be much better. And the main summary outcome slide is what you have on the right. On the y-axis, you have proportions of patients without the event. So the event is discontinuation for any cause. So higher is better. And on the x-axis, you have time to discontinuation. Another remarkable aspect of the study, this was a controlled study for 18 months. And what you see here is that basically most of the drugs were the same. And patients, almost half of the patients discontinued treatment for any reason by 6 months. The olanzapine in red looks a little bit better than the other drugs, and that is perhaps because the dose range included a higher dose of olanzapine. And I think that was well thought out by the Lilly scientists who made the recommendation. But the other agents, the other so-called atypical antipsychotics just look just like perfenazine, which is in the black. Okay, so this supports the view that these agents in general are no better in terms of efficacy than the old drugs. And that's important to keep in mind. Now, what about side effects? So this is a very busy slide, and I apologize. This is taken from up to date, from the most recent chapter. And it looks at the side effects of the different medications. And you have, I believe, all of the current, now they're called second generation agents on the top, yeah? And a few examples at the bottom of the first generation agents, and those are listed in the first column. And let me just highlight a few things because this is very busy. So for example, you have clozapine here, oops. And you see that clozapine is an agent that has a lot of metabolic side effects, weight gain, glucose abnormalities, hyperlipidemia, but remarkably has very little EPS. So that's why you have just one cross. Conversely, haloperidol has little metabolic side effects. I would dispute that that haloperidol is this, has 2 crosses for weight gain. But haloperidol has a lot of EPS, which is shown here. Now, some of the so-called second generation agents, like risperidone, have significant metabolic side effects, not as bad as clozapine, but they also have significant and clinically meaningful Parkinsonism. They have two crosses for Parkinsonism, dystonia, tardive dyskinesia. Yeah. So again, this illustrates how this concept of atypicals versus typicals is not a true category. Some of the new drugs, the newest one, which is called lumateperone, you see there, looks pretty good in terms of metabolic syndrome and EPS. However, it's still early on because this drug hasn't been used much and there's no published long-term studies. Now we move to what most of our patients are going to have to endure, sadly, which is a recurrence of psychosis. So most patients will have a psychotic relapse despite compliance. So after 2 years, even with compliance, about 50% of patients will have a relapse. So what is available to deal with the recurrence? We'll talk about a few things. Engage the family, so family treatments. Recognize the non-compliance and consider a long-acting antipsychotic, and consider a psychosocial intervention that we have available through our department, which is assertive community treatment. And I will spend a few minutes on each of these. So in terms of family therapy, this comes from, the theoretical formulation comes from the 70s in Britain. George Brown did some of the seminal studies with families of patients, young patients who had been hospitalized for their first episode. And he interviewed these families and recorded their responses to various questions and found that some, not all of the families, rated high on hostile, critical, and so-called over-involved comments. And he labeled these families as high in expressed emotion. That was the first step. The next step was to see what happened to the patients when they returned to live, to live with their family of origin. And what happened was that the patients who had been stabilized on medication and had responded well, the ones that returned to live with their family and the family rated high in expressed emotion, and if they had extensive face-to-face contact with the family, those patients had twice the risk of relapse as patients who returned to a family rated low in expressed emotion. This has been replicated multiple times across multiple communities and countries. So that's the relationship between high expressed emotion and risk of relapse. This relationship, however, is not specific to schizophrenia. It is seen in bipolar disorder, in depression, in anorexia, and in multiple chronic medical illnesses that affect young people who reside with family members, epilepsy, asthma, so it shouldn't be surprising. So families do not cause schizophrenia. But this opened the door, of course, to looking at interventions, family interventions. And this is from a meta-analysis from the Cochrane database. And this looked at all studies that look at family interventions that use at least 5 sessions with different backgrounds, type of intervention. So some were behavioral therapy, some were psychoeducation, some were more psychodynamically motivated, a large sample of individuals, 32 controlled trials. Bottom line, there's a reduction in the frequency of relapse compared to the control condition in about half, with a number needed to treat of about 7. So it is something clearly worth doing. And it is not as complicated as it seems. So these are some of the general principles that have been found to be effective and common to the interventions that work. First of all, it's a lot about psychoeducation with the family. present schizophrenia as a brain disorder. We've talked about this, and that this is not due to poor parenting. I can't emphasize that enough. Parents and patients need to hear that. Also, repeat over and over and explain the common sense view that, like any chronic relapsing illness with exacerbations, stress is going to contribute to relapses of the illness. Explain, for example, that some of the symptoms like avolition and asociality are not laziness. So take away the negative connotations for the family. Explain that delusions and hallucinations are distressing symptoms likely to improve with treatment and not contribute to stigmatizing these symptoms as craziness. Teach how to recognize early signs of relapse. The relapses in schizophrenia usually take weeks or months, and intervening early on can make a huge difference, and having the family as an ally is important. Explain the importance of medication adherence, educate about comorbidity with substance use, and foster optimism. Remind families that schizophrenia is a heterogeneous disorder and good outcomes are possible and likely. Now, the other component to deal with recurrent psychosis is compliance. And on the left, you see this illustration from a very important study in Finland. This was a large number of first episode patients who were hospitalized, treated, and discharged. And what this slide shows that half of them did not fill their prescriptions after a month of being discharged. Half of them. On the right, this is a summary from another study, a meta-analysis that shows that clearly in chronic patients now, discontinuation of medication clearly increases the risk of relapse, and even dose reduction. And when the dose goes below 5 milligrams a day of equivalence to haloperidol equivalence, the risk of relapse goes up. That's in average. That doesn't mean there's no patients that can do very well with 2 or 3 milligrams of haloperidol. But that's another very important issue. So this problem with compliance and the direct relationship between poor compliance and relapse takes us to considering long-acting injectable antipsychotics. And this is the only thing I'm going to say about long-acting. I'm not going to go into these compounds. This is what we have available. The only thing I'm going to say is do not start the depot antipsychotic until you're convinced that the patient will tolerate. So giving someone 2 or 3 days of
Dr. Bustillo?
It looks like he may have froze out.
for recurrent psychosis that I want to spend a minute on is, can you still hear me?
Yes.
Okay, is assertive community treatment. I got a message that my internet connection was unstable. So assertive community treatment is a team-based program in which the locus of care is in the community. It is not in the clinic. The goals are maintaining safe residency in the community so that patients are not in and out of the hospital or ending up in jail, compliance with prescribed medications, and minimal utilization of emergency psychiatric services. The indications, the type of patients, are for patients that have a history of repeated hospitalization or homelessness. We have many patients like that. We are very fortunate. Our department has an excellent ACT program led by Drs. Bonham. And these are some of the characteristics of the patients: severe illness with persistent psychosis, poor insight, cognitive impairment, poor compliance, very common, comorbid substance use, very common, and limited family and other support. I'm rushing a little bit because I want to catch up. In terms of the efficacy, this slide just comes from a meta-analysis that showed with 6 randomized controlled studies that ACT is better than just standard case management in preventing homelessness. and the effect size is moderate. This has been replicated many times. Okay, so we've talked about treatment in the first episode and the importance of choosing your antipsychotic. We've talked about relapses and the importance of family therapy, depot antipsychotics, and ACT. And now we're going to talk about persistent psychosis. And for most of us who treat patients with severe chronic mental illness for long periods of time, we will end up seeing this problem probably 30% of our patients. Persistent psychosis, persistent hallucinations, delusions may be improved, but that they continue. The treatment of choice for these patients is Clozapine, the first true atypical antipsychotic. So not only this was an atypical antipsychotic, it's not a neuroleptic, but for reasons we don't understand, it turned out to be the only drug that is effective when other drugs have failed. It's the only drug that has an indication for treatment-resistant schizophrenia. And this was found for the first time in the 1980s by John Kane and his team, and with the study that was called Study 80. And this is a study, again, I want to recommend residents to look at this study. It's public in the Archives of General Psychiatry. It was called Clozapine for Treatment-Resistant Schizophrenia, and it was compared to chlorpromazine, the first antipsychotic. And Kane et al. Found very treatment-resistant patients. So they had to have failed three typical agents, plus fail a prospective trial with high doses of haloperidol. These patients were inpatient. They were all pretty sick people, and they were treated for 6 weeks. And I mean, the great finding was that Clozapine was 30% effective, while chlorpromazine was only 4% effective. There's been, for many of the so-called atypical agents, these kind of studies have been attempted, have been implemented, and they have all failed. So it's not that they haven't been tried. So for olanzapine, for quetiapine, for risperidone, for ziprasidone, for aripiprazole, they have been tried and they have failed. They are not treatment-resistant agents, unfortunately. Now, that was an inpatient study for super resistant patients. What about more garden variety? Patients were treated for 12 months, for 18 months. And what you see here is the patients randomized to Clozapine versus patients randomized to another antipsychotic after they had failed an initial antipsychotic. And not surprising, Clozapine did the best. So 80% of patients assigned to Clozapine stayed on the medication because they felt it was efficacious. So Clozapine should be used not just in the sickest of the sick, but on all patients with schizophrenia that have failed 1 or 2 antipsychotics and continue to have any psychotic symptoms. Now, well, why not use it with everyone? Well, fortunately, there was this study also done by Jeffrey Lieberman. This was a study that was done in China. And they looked at first episode schizophrenia patients randomized to Clozapine or chlorpromazine. There was no difference. And we don't understand why this is the case, but this is clearly the results of a very careful study. So Clozapine is not indicated for first episode schizophrenia. I'm going to rush through these slides a little bit faster. How to get started. The indication is pervasive psychosis, not intolerability. It's critical to educate the patient to not rush Clozapine. Patients will feel worse before they feel better because it takes time to reach the therapeutic dose. You need to get several labs to prevent agranulocytosis, metabolic syndrome, and myocarditis. You need to register the patient in the national registry. You have to titrate the patient slowly, about 100 milligrams a week if you do it outpatient, and gradually cross taper the medications that the patient is on at this point. And the trial, especially an outpatient trial, usually takes 3 to 6 months. And you need to be prepared to discontinue the medication because about 50% of patients fail. These are the main complications that you're familiar with. Agranulocytosis is rare. Seizures is dose-related. Myocarditis is very rare. If it's going to happen, it happens in the first 12 weeks. Metabolic syndrome is very common. If you can get patients to start metformin at the same time. And then there's all these other unpleasant, more common side effects. Let me highlight constipation is a big problem. You need to anticipate it. OCD happens late in the illness, in the treatment, months or years, up to 40% responds well to SRIs. Let's say the patient fails clozapine or doesn't want to take it or doesn't tolerate it, and they have persistent delusions and hallucinations. Cognitive behavioral therapy has been found to be effective for these patients. It is based on engaging in a logical examination of the maladaptive aspects of the delusions. It's critical to spend time understanding the patient's interpretation of the symptoms, the meaning of the symptoms for the patient, and then working collaboratively to develop more rational interpretations and adaptive behaviors. Clearly, CBT now has been used for psychotic symptoms way over 20 years. This is a meta-analysis. Pay attention, please, to the third row. CBT versus all other psychosocial treatments for positive symptoms. CBT was more effective. That's why the red square is to the right of 0. The effect size is only 0.2, which is a small effect size, but it's a reliable effect size. What else is available if CBT fails or if clozapine fails? Well, one of the earliest treatments, or if not the earliest, effective biological treatment in psychiatry is electroconvulsive therapy. And this is from an important study done in Hillside about 7 years ago. And this study looked at patients who partially responded to clozapine. And then they were randomly assigned the green group to remain on clozapine, the orange group to start ECT for 8 weeks. It's not a double-blind study, but ECT had the expected antipsychotic effect. We are fortunate to have an excellent ECT service that has been enlarged by Dr. Abbott and Dr. Miller and several others, so that they have been taking our patients with persistent psychosis now. And so our patients that fail clozapine or have partial response, we routinely send them to ECT. Some of those patients do not need more than a course. Some patients need maintenance ECT, and we have several of those patients. All right, our last outcome that is important is functional impairment. And this is all, it's a broad set of outcomes that involves cognition deficits, negative symptoms, impairment in the community, in everyday skills, work skills, interpersonal relationships. This is a busy slide, but I think it's very illustrative, and it's from a very recent study that I like a lot. It's a naturalistic longitudinal study done in Italy. About 1,000 chronic patients with schizophrenia were assessed at time 0 at the beginning, and they had symptoms assessments and cognitive assessments. And then they were assessed for their function in the community 4 years later. And they looked at a model about what factors predict function. The bottom line is neurocognition at baseline. Cognitive function was the largest prediction or predictor of functioning down the road. The better neurocognition, the better the cognitive, the social functioning. Symptoms only mildly predicted function down the road. Psychotic symptoms, to a low extent, predicted function in terms of work skills. Disorganization symptoms predicted predicted work skills through social cognition. Negative symptoms, abolition, predicted interpersonal relationship deficits. So the bottom line here is positive symptoms do not predict down the road functioning very well. Negative symptoms and cognition do. So what are the treatment available that are available? Social skills training. This is a behavioral training focused on specific situations, problems, and activities. The ultimate goal of this training is generalization of learned skills to community activities. We are fortunate to have the psychosocial rehabilitation program in our department. They do social skills training, and we refer patients there all the time. Just very
Looks like Dr. Bustillo is having a poor internet. Good.
Can you hear me?
We can hear you now.
Okay. Less than 20% of patients with chronic mental illness have competitive employment. And the most recent approach over the last 20 years to improve that is what's called supported employment, in which the patient, the agency helps the patient find and maintain a job in the competitive job market. There's been many meta-analyses. This is one that include 18 randomized clinical trials and found that supportive employment to be 34% more effective than pre-vocational training, achieving the desired outcome of competitive employment. And I'm not going to go into this because I'm running out of time, and I'm going to stop now. I have just these recommendation slides, but I think I'm going to stop and leave you just 8 minutes for questions.
So folks, raise your hand or speak up, even better. Maybe I'll start with a question, Dr. Bustillo.
Sure.
First, you're no doubt a great teacher. Congratulations. We all learned a lot.
Thank you.
Thank you, Dr. Bustillo. Here's my question.
Sure.
In the Katie study,
Yeah.
so the comparison was perfenazine against everybody.
Yes.
Now, as you pointed out, not all atypical antipsychotics are created equal.
Yes.
And is it correct that if you looked at the comparison of one-to-one, say, perfenazine versus olanzapine,
Yes.
olanzapine separated from perfenazine in terms of longer time to discontinuation? Is that correct?
Yes, I believe that's correct.
So although the primary outcome in the study was everybody's the same, when you look at them one by one, the only one that separated was olanzapine.
That is correct. And I think that's important. And you know, when I teach the residents and they tell me, okay, if patient failed the first drug, should we go to Clozapine right away because it's the only one that has been found to be effective for treatment-resistant schizophrenia? I will say, you know, tell the patients and the family that that's true, that's correct, and that it is possible to start Clozapine right away. And I've had a couple patients over this last 20 years that have gone straight from one antipsychotic to Clozapine.
Sure. Of course,
but if you also educate the patient about the side effects of Clozapine, and they say, well, we want to wait. If the patient is compliant, I will almost always go to olanzapine as a second-line drug because of the KD.
But as you pointed out, and I would agree with you, the side effects of olanzapine sometimes make it a hard choice because of the side effects. And of course, it's a combination of not only efficacy, but also tolerance and side effects. So I would agree with your approach. Other questions or comments, folks?
This is Paul Romo. Quick question. Is there any issue that you found combining phentermine with one of the ones that cause metabolic syndrome? Like, does the stimulant property disrupt the antipsychotic property if you need something more aggressive than metformin?
I don't know. That's a good question, and I really don't know, Paul. I'd be curious if anybody else has a thought on that.
We want to hear more questions from our residents. Don't miss this opportunity, folks.
Dr. Bustillo, if you wouldn't mind going back and just showing us the neuropil structure slide again. Your slides were frozen at the time, but that.
Yes, I'm sorry. Let's see. Can you see it there?
Yes, that's great.
All right. What's the question?
No, just wondered if you could explain that. So if I'm understood you correctly, there's not actually any neuronal loss. It's just a structural change.
That's right. So, so this previous slide shows the very well replicated finding that the cortex in schizophrenia is a little bit thinner. I mean, that looks like a lot in this slide. But that's an effect size. The actual reduction, we're talking about 1 or 2 or 3% reduction, in volume. Okay, so you need hundreds of patients to be able to see that in a study. What accounts for that reduction in cortex? One possibility that it's like what happens in Alzheimer's disease or in vascular dementia, that there's loss of neurons. And these neurons are replaced by scarring. And that's what accounts for the contraction of the cortex. That is clearly not the case in schizophrenia. That's what this slide tries to illustrate. That, on the right side, you see that the cortex, the 6 layers are a little bit thinner. They're not as thick, but the number of neurons are drawn, and they are the same number of neurons, the triangles and the circles. What is different is the density of the neuropil is reduced in schizophrenia for reasons that we don't understand. And that probably, this is not known either, but probably that's what accounts for most of the contraction in volume. Conversely, just as important, and optimistically, this shows that doesn't mean that patients' cortex potentially cannot sort of recover because there's no loss of neurons. Okay?
And are synaptic connections reduced or we don't know?
Yeah, the synaptic connection. So the dendritic trees which connect with axonal buds. There's fewer number of those across the cortex, more in some layers of the cortex, like layer 3 and 4. But that's the reduction, and those dendritic trees occupy a remarkable volume of the total cortex. That's what's reduced in schizophrenia. That's a good question. Any other questions?
Bustillo, this is Dr. Dean. Can you hear me?
I can't hear you.
So we're talking about a reduction in synaptic or dendritic connection to other axons. Has there been any study, is that always present in patients that are found to have schizophrenia, or does it evolve with the onset of symptoms?
Okay. So your question is it always found in patients with schizophrenia? That's one part of the question. And the other question is, does it get worse with time?
Yeah, like if we were able to retrospectively look at patients in our early clinic that we think will go into more of a full schizophrenia, would we find the same lacking of dendritic connection to axons as patients that have an established diagnosis?
So that's an excellent question. But I mean, and I don't think we know that, so these studies, these are postmortem studies. So these are end of stage studies. So we don't know what the brain of these patients look like in terms of these dendritic measurements when they first got ill, because their brain is dissected when they die, and they're usually in their 50s or 60s or later, okay? There are imaging studies in vivo that look at sort of proxies for this dendritic retraction and are suggestive that this process is going on, perhaps to a lesser degree early on. Now, what it is known is that the gray matter thickness that I showed you here, yeah, that is progressive in schizophrenia. And this has been shown in many studies. Yeah, these are longitudinal studies with MRIs, and the patient is imaged when they first come, and then they're imaged a year later, and 5 years later, and 12 years later. The cortex contracts a little bit more with time, and then it seems to level off. All right? Now, that doesn't mean that that's what's happening to the synaptic trees, but it is plausible that that's what's happening. We don't understand why that's happening.
Thank you.
So we have now reached a minute past the top of the hour. I'm sure many of you have other meetings. Any closing remarks, Dr. Bustillo?
No, I enjoyed the opportunity to present, and look forward to talking with several of you about your research interests in psychosis or any other areas. Thank you very much for your time.
Thank you, Dr.